Okay, I think the challenge is not showing the cases. The challenge is keeping the time. So I hope everything goes well. So this is about this is a case based, so I can stop whenever there's a time which exceeds. It's on the unusual and challenging cases, and we'll deal with some of them. So this is the first case. It's a 61-year-old male. He's a CKD patient and on treatment since 2004. And there was a recent weight loss 4 kilogram in 1 year. So there was a neck swelling since few years, but that was not really investigated. But recent PET CT was done, which shows left thyroid lobe focal uptake. In view of his weight loss, he went for a sonography, and he came to me for this nodule. And this was a nodule which we can see here. That's the trachea, this right, left, and this thing. But the entire neck looked quite swollen, as you can see. A small nodule which is very peculiar, and the rest of it looked almost like thyroid, but I was slightly surprised that how big is this thyroid, and it is displacing the carotid sheet to each corner. You can see this is the left carotid, that's the right carotid, that's the trachea, that's a small lesion. This lesion showed a lot of vascularity, so it was matching with the PET scan which was reported. This is again another cystic component the same nodule had, and you can see the entire extent, and this is a slightly hard lesion which is showing vascularity. So for sure it looked like a suspicious nodule because it is hypoechoic, it shows vascularity, it is PET positive. So the next thing we would do is simply do the FNEC, and I did the FNEC. This turned out to be the PTC because and it is matching with everything. But what was this entire thyroid which was looking bizarre and very large and extending to both the carotid sheets without actually the nodularity. So it is not a typical multinodular thyroid. It is just one lesion and this abnormality. So we went back and saw the CT, and that echogenicity is completely due to the fat replacement. So if you go back now, and you can see this is the entire visceral fat which is coming, which is going behind. And such a scenario is known in CRF patients because sometimes they have an amyloid deposition and amyloid change. So thyroid itself is a very minuscule, which is showing the primary lesion, and rest of it is extensive lesion, which is explained by that now this pattern which we saw. It is typical fat. So PET CT done shows thyroid left focal uptake with diffuse lipomatosis, which is known in this case as familial amyloidosis. Thyroid diffuse lipomatosis with focal left lobe. PTC was the diagnosis in this case. This has been described in literature that sometimes in such patients you tend to get such. So there's a nodule which is very small. The rest of it is bizarre, but that is not so abnormal. Let's go to the case 2. 5 months gestation with bilateral thyroid nodules and slight increase in over a period of time. So during pregnancy it looked little larger, so someone told her to go for FNEC, and they did the TIRADS calculations, and they did TIRADS applied, and they did the FNEC of the largest nodule because it was very large, and that was showing follicular lesion of undetermined significance, which is what we were discussing what to do in these cases. And right lobe showed cystic colloid goiter. That was the previous ultrasound. So this is the summary with which patient came to us. Now you can see in this picture here in the video, you can see that's a so-called cystic lesion in the right lobe. The left lobe nodule was very typical isoechoic and big lesion, and this another nodule which looks somewhat solid. As you can see, this is one nodule, this is second nodule. The second nodule looks a little bit unusual, and probably in our opinion this is the one which should have been subjected to FNEC. And most important thing is, while doing this ultrasound, we picked up one cystic lesion between the carotid and jugular, and this is a level 3 lymph node, as you can see here. So putting 1 + 1, we have had FNEC of the opposite side, which was already done, and it showed follicular lesion of undetermined significance. But this is benign looking nodule, and this is the abnormal nodule. So knowing there is the abnormal cystic lymph node without much of flow except for the peripheral flow, I decided to do the FNEC of this and this mass. And this obviously was the PTC again, and this was a metastasis. So patient went ahead, even though she was pregnant, they thought they will do the total thyroidectomy, and the final histology was FNAC was Bethesda 6 from the right lobe nodule. FNAC of the right level 3 nodule was fluid only, no cells, because that's what PTC metastasis sometimes can lead to, and hemithyroidectomy was done. It showed multifocal papillary cancer, and the opposite nodule was the follicular lesion, which was this large lesion, which was not abnormal, but it was a follicular adenoma. So I think we'll have these difficulties once in a while. Let's go to case 3. In this case, this is a 51-year-old female, and I'll show you the video, what we saw. This is similar mild neck swelling and pain. Previous EAG revealed spongiform hypoechoic lesions in both lobes. So they almost kind of ignored it, saying these are spongiform, but they look a little bit abnormal considering, their bilateral, there's a bit of pain, and the similar lesion is seen in the opposite lobe. There's a bit of vascularity within. So this is solid, and there's a vascularity. So FNAC was what was asked for. But sometimes you realize, I thought maybe this is a more than a typical PTC, so we will not do the FNAC. And in this case, I in fact convinced the patient that we'll do the biopsy. This was important in my opinion, because I thought this could be a lymphomatous involvement, and this could be causing us confusion. It could be focal thyroiditis and whatnot. So we did the biopsy of each, and we were glad that we did the biopsy. So the biopsy was done from both the lobes, and you can see here, that's the one side nodule, that's the opposite side nodule. So I had to do the FNAC as well as biopsy. I thought we'll get early diagnosis if it is PTC or something, and a good core biopsy was done, and it turned out to be a granulomatous thyroiditis, and they were very sure it is a tubercular type, so which is very unusual. I think in my practice I've seen only 4 to 5 times the actually proven COX, and this was one example. So, but since we did not think of COX, we had not sent the sample for gene expert, so we had to do another biopsy, and the gene expert also was positive in this case. So this was a typical, very atypical, unusual case of a thyroid nodule. And another point which probably would make some impact in such cases, when you suspect a little bit not the regular run-of-the-mill lesion, then you would probably do the biopsy, which will give a better yield. So this was the cancer, assumed to be cancer, but this turned out to be a typical tuberculosis, and these are the giant cells. I'm not the expert here, but they were quite sure that what was happening. So I was keen to know whether it is a granulomatous thyroiditis. They said no, this is a tuberculosis itself. So that was the tuberculosis of the COX of the thyroid. The patient had no other lesions. Now, pseudo or true nodule, that can be a confusion, and the literature describes in the background of diffuse thyroiditis, you tend to see a echogenic, very much bright nodule, which we call white knight nodule, and these are assumed to be a normal rest of thyroid tissue, which would generally can be ignored. And a Thyroid's calculator is not applied to such areas because the entire background is a thyroiditis. So there are 2 points. One is you have to always look at the background thyroid parenchyma in any given Thyroid's calculation. You may have to mention it even otherwise. That the reasons are 2. One is these patients are prone for small PTCs after 10 years or so, or sometimes they can develop lymphomas. So this is one such example, and this is another example where you can see actually the nodule looks harder than the rest of the gland, but this was not investigated, and we thought this is a typical white nodule. Similar patient came to me recently, and there was similar large nodule here, and the rest of the background was completely atrophic thyroid with thyroiditis, and we thought this is a white knight nodule, but there was a FNAC which was done, and it showed this is a follicular lesion. So that prompted us to take an action about this, because we thought we would not just pass it as white knight nodule. So we explained to the patient that this is an unusual nodule. Instead of doing the repeat FNAC, we'll go for your surgery, and the surgery was done. This was that large nodule, and this nodule was not PTC. The PTC was incidental small here, which we did not pick up on ultrasound, because that's what can happen in Hashimoto's and similar backgrounds. So this is the point to be taken into consideration, that sometimes you would, even though you want to pick up those small cancers, you'll miss. And this was the gross specimen. When they finally gave the diagnosis, they called it a papillary carcinoma, which is very small, and follicular adenoma is what was given to this. So the white knight actually is the follicular adenoma, and the small cancer is not something. But in all, the patient was at least happy that she went and did the surgery of right hemithyroidectomy. Now, this is a companion case. This is again a typical thyroiditis, which is very bizarre and leading to parenchymal reduced echogenicity. Compare this with the strap muscle, and you can see the thyroid is now nearly looking the isoechoic to strap muscle. That means it has less, iodine, and it has depleted, so it looks a little different. But again, in the same background, you tend to pick up those small nodule, and this was again a proven PTC against the background of Hashimoto's thyroiditis. So I think all in all, patients who have had Hashimoto's thyroiditis, they tend to have atrophic, bizarre, disorganized thyroid. Keep watch for looking out those small malignant lesions, or even sometimes after 10 years or so, they tend to also develop lymphomas. Let's go to another case. A patient has come for head and neck cancer, and there was a incidental left lobe nodule. And we tend to pick up a lot of incidental nodule, and patient goes for now 2 surgeries. One is the tongue or something, whatever else is there, plus the thyroid is always a additional thing. So now this was the lesion which we thought is taller, hypoechoic, and they tend to show some kind of echogenic foci within. So my juniors said this could be PTC, but again, when you apply vascularity, there is none here, and the calcification is sometimes we see in a colloidal nodule. And when I did the FNAC of this, it turned out to be a colloidal degeneration nodule, and it was not a PTC. So this is also a teaching point, that some lesions, they tend to look abnormal, but they could be simply benign lesion. This was the FNAC which was done from that area, and there was no malignancy in that. Now this is another case, 55-year-old female. She's a doctor's mother, and they felt there's a gradually increasing neck swelling with occasional breathing difficulty. Dr. Prathamesh Pai was there in the morning lecture. It is his case. On prior EVG, few years ago, someone had reported on ultrasound the MNG, that typical MNG term is used so often that it was called as goiter. And we can't really blame them. You can see the lesions are so bizarre and large. You can see the entire left lobe, right lobe is replaced by a large tumor which is hypoechoic, but kind of it appeared a little soft. There was a significant vascularity. This is a abdominal probe, curvilinear probe used, because you can imagine the extent of this lesion. That's the carotid on the left side, and the entire lesion is now going posteriorly in the prevertebral space, and you can see the entire lesion. But for all this extent, this patient was reasonably well preserved, except for a bit of mild swallowing difficulty occasionally, but except for the swelling, there was not much complaint. Serum calcitonin was also asked for by us, because we thought it should not be something unusual, and sometimes that helps. It was normal, and you can see again the tumor which has gone here and extending and displacing the carotid. So this is the left carotid, and this is the right carotid. So you can see this coronal plane, it is going right behind the tracheal area. And this was the CT which was given to me later on. And this looked like a thyroid. It is isthmus, and this is the entire lesion which is displacing the carotid. And now you see these images, and it corresponds correctly. So we did the biopsy, assuming it could be anaplastic carcinoma, because this is what it looked like. It is going behind the larynx and reaching the opposite carotid sheath, and we thought the biopsy should be done. The only good thing in this case was there were not many nodes, and we thought for such a scenario you should expect a node. So we did the biopsy. You can get the final diagnosis, and the biopsy showed that this was a solitary fibrous tumor. So it is a very unusual case, which is also called as hemangiopericytoma, and that is one of the odd bits, but we would get them once in a while. They are uncommon, less than 1% of fibrous tumors affecting the head and neck, often present with painless mass, the way it was there, swelling in the neck as a symptom, and can be detected incidentally as a palpable thyroid nodule. Malignant also lesions are known, and they can sometimes metastasize. And that was a very unusual case. Now coming to a case which we thought there is a right anterior neck swelling since 8 months. There was no rapid growth. Previous FNAC was suggestive of medullary thyroid cancer. Calcitonin and CE are normal. I think this is the kind of very important point for us to know that even though it looked like MTC, the calcitonin and CE levels were normal. And on UAG and CT, appearance was like a large goiter extending across the spine. But what was the unusual here is in this plane, you can see as though there is some tracheal adherence here. You can the lesion. This is the tracheal wall. That's the air echo, and this is the cartilage echo. And you can see the lesion which is protruding in. There was a left vocal cord palsy, and the lesion was obviously going into the region of the left recurrent nerve, laryngeal nerve. You can see in this section a normal right half of thyroid and abnormal left half of thyroid with bit of tracheal invasion. So we thought we would do the biopsy. A CT was also done and a biopsy was done. Here, you can see now the extent of the lesion better here. And there was a abnormal looking node which was supraclavicular, and this is the supraclavicular node which is partially cystic and solid node, and that's the abnormal node, and this is the entire thyroid gland. We were thinking this is a tracheal invasion. We cautioned them that it could be slightly involving the thing, but overall the biopsy was done, and after the surgery was done, it was not a regular tumor, but it was a hyalinizing trabecular tumor, that is HTT of the thyroid, which is considered as less neoplastic compared to the other lesion. So this is one odd bit lesion, even that's why it explains the calcitonin being normal. So I think this is again one of the unusual odd bits which we should keep in mind, that hyalinizing trabecular tumor can occur and involve the thyroid, and it can look almost like an anaplastic cancer. I think this should be, the last case. This is a 50-year-old female, one of my friend's aunt, and she's had COVID chest screening. And they found during that COVID chest screening, there was incidental thyroid nodule which was invading the trachea. As you can see the lesion, this is the picture she came to us with. When I did her ultrasound, I can see there's a lesion in the thyroid bed, which is kind of running across the thyroid and trachea, and we thought it is invading the trachea. We offered the biopsy, and I did the biopsy and FNAC as well. We thought this could be a PTC which is invading the tracheal wall and which has been growing over a period of time from COVID to non-COVID phase. The endoscopy also was done, and they felt the mucosa was intact. And when they actually did this biopsy and it was studied, one more biopsy was done by the through the endoscope, and both these things showed a normal thyroid tissue. So this is a ectopic thyroid tissue which can sometimes invade the thyroid, and it can actually look so bizarre, and it can cause confusing picture. And what is the important point? That it can look similar to the metastatic lesion which can actually invade the trachea, as you can see in certain cases, except for the calcification. And that's where the Sheen classification will help us to understand how much is the probability. And this is another case who's had thyroidectomy way back a few years ago. Now it's come back with a recurrent tumor, which is actually into metastatic lesion. So I think this will stop here because of the time. I have many cases, but we would stop at this point. Thank you so much.